brief overview of shock. So shock is defined as an inability to perfuse end organs, and it's associated with a low systolic blood pressure. When we look at end organs, we can detect it clinically. So kidneys, decreased renal perfusion is going to lead to decreased urine output. Decreased in perfusion of the brain will lead to a decrease in GCS, which might present as agitation and confusion, and then eventually a drop in GCS and the loss of consciousness. And then things like the skin, as you perfuse the skin less, you lose this skin turgor and less sweat, and you can detect that clinically. So shock comes in a few different flavors. So the main one will be hypovolemic, and that can be either a volume loss, either due to hemorrhage and trauma, or whether or not a patient has got ongoing diarrhea and vomiting, which means they've lost a lot of their volume, and that will present with a hypovolemic shock. Cardiogenic shock is when the heart fails to work the way it should as a pump, and that could be due to an acute MI, or it could be due to obstructive type problems such as aortic stenosis, or whether or not someone's got a cardiomyopathy, or any sort of cause of outflow obstruction, including tamponade, as that eventually will cause outflow obstruction, as will attention pneumothorax. And then problems with distribution, so things like anaphylaxis and neurogenic anaphylaxis will have skin manifestations, will have a response to an antigen or an allergy, and that will cause swelling, laryngoedema, and a massive drop in blood pressure. It's treated with IM adrenaline and corticosteroids. And then neurogenic, not to be confused with spinal shock. So neurogenic is when you have a high up lesion due to some form of trauma or even a malignancy growing, and that tends to cause a high up will block the sympathetic chain, and you lose your sympathetic drive to the heart. And that is what you'll see in the question. Well, the patient will have a low blood pressure and also a low heart rate, which is obviously an abnormal response. You would expect someone with a low blood pressure to have a high heart rate to compensate, but not a neurogenic shock. And that's not the same as spinal shocks. So spinal shocks, when you have a spinal injury, you lose your reflexes, you lose your cavernous bulbous response, which is when you do a PR, or actually you either tug the catheter whilst doing a PR and you check for anal tone, and you'll lose that reflex, which is at the bottom of the spinal cord, and that's in spinal shock, not to be confused with neurogenic shock. And then septic shock, you have a pathogen, which is releasing an endotoxin, and this endotoxin causes a gross amount of increases vascular permeability, and that causes fluid loss. And in the question, the key to septic shock, well, the patient will have positive blood cultures or be pyrexic, whereas a lot of the other ones won't give you a pyrexia. So looking at shock, it can be classified and looked upon in four main ways. It comes into four groups. So group one, stage one rather, is when you lose not to 15% of your blood volume, so 0.75 per liter, and you usually have a normal blood pressure, a normal heart rate, and everything is usually pretty normal. So this is just, you might have a mild bit of being anxious, but for the most part things will remain normal. But you could be slightly tachy. So if a young person loses this amount of blood and they're beating at about 90 or just under 100, that would still be abnormal. And obviously different patients compensate for different things. So young, athletic, or even pregnant women are very dangerous in trauma because they can compensate for a very long time, whereas the elderly will not compensate as they have very little physiological reserve. So stage two would be 15 to 30% of blood loss, and you see that this is when you drop your blood pressure and your heart rate will increase as a reflex to this. You might increase your respiratory rate and your urine output will decrease. So the urine output, usually you should expect 1 milliliter per kilogram per hour is what you look for. So if you have a 80 kilogram man, you would expect 80 mils an hour in the bag, but you'll accept anything up to 0.5. So an 80 kilogram man, you would accept 40 milliliters of urine per hour. And then CNS-wise, this end organ perfusion, as we mentioned, they become slightly anxious. Stage three is when you start to see a lot of patients coming in trauma from road traffic accidents, and they've lost 30 to 40% of their volume, which correlates usually to 1.5 to 2 liters. Obviously, it's different depending on the size of the patient. And you'll have a decrease in blood pressure with 120 to 140 heart rate, and a massive widening of the pulse pressure as well will be also a sign that you'll see. The respiratory rate will increase, and the urine output will decrease quite substantially, and the patient will become even more anxious. And then stage 4 is a bit of a tricky one, so they lost 40% of their blood volume, which is over 2 liters. For most patients, a massive decrease in blood pressure with a compensating increase in heart rate. The respiratory rate will be even higher as they're trying to blow off more of the acid as they become more acidotic due to poor tissue perfusion, and the urine output will be next to nothing. They'll be confused, they'll be lethargic, they're usually quite agitated, so at the scenes of massive accidents, it's not unusual for ambulance crew to have to sedate people that have got have lost a lot of volume, and this is just because of the confusion and sometimes aggression that's caused through poor perfusion of the brain. So if you look at the losses, the way to remember it is if you follow tennis, it's tennis scores, so 0 to 15, 15 to 30, 30 to 40, and 40 love. So 40, when you finish at 40, usually game's done, isn't it? So the treatment of any form of shock is target aimed resuscitation. So you replace like with like, meaning that if someone has lost 2 liters of blood, you aim to replace that with blood as opposed to just giving them copious amounts of fluid. And this is because you can cause problems with hypothermia, you can cause problems with coagulability, and most patients in trauma do have increased tendency to bleed. They're coagulopathic. So the other thing is, previously ATLS used to say giving lots of fluids, but now it's mainly aimed at just getting systolic blood pressures back. So basically you aim for a systolic of about 90, or you aim to restore pulses, and that's certainly what they do in battlefield injuries. They aim just to restore the pulse, because giving a patient too high blood pressure in this situation can cause increased hemorrhaging and bleeding, and so you basically aim just to resuscitate them until they have good pulses throughout. The other thing to say is make sure you're monitoring vital signs. That can be done either centrally via a central line. Other things you can do is, obviously, a patient will need a catheter, and you'll be on continuous monitoring and ECG monitoring throughout. And then the use of vasopressors is used in intensive care settings. So, and again, that's used usually centrally given, and that's used to maintain blood pressure. And the aim of shock is to avoid multi-organ failure and to treat the underlying cause. So the questions when a patient has come in clearly in shock, the first-line treatment will always be resuscitation, and that will be giving them a fluid that's in the EMQ with a question. And then second would be to start treatment that will help. So if it's septic, then the treatment would obviously be antibiotics. If a patient's got blunt force trauma to the abdomen and has ruptured a visceral organ, then the treatment is obviously theatre. But for the purposes of questions, the first line treatment is always fluid resuscitation.